on providers following progesterone levels. And if it's below a certain level, and this is usually in someone who might have had a miscarriage or multiple miscarriages in the past, and they get pregnant and they'll follow progesterone levels, and then they'll start supplementing them based on a progesterone level. What is the evidence behind that, or is there any evidence to do something like that?
So the reason why anyone would think to supplement in the setting of a pregnancy conceived on your own outside of IVF is this idea that there might be something inherently wrong with your body's ability to produce progesterone, aka a luteal phase defect, right? And this used to be like a common diagnosis in my field that people would throw out all the time and say, oh, you must have a luteal phase defect. That's why you're having infertility. That's why you're having miscarriages. And I'll actually send you a link to that ASRM guideline that recently came out, basically explaining why luteal phase defect is probably not a real thing. Yes, you're supposed to have, you know, like a 12 to 14 day luteal phase. Luteal phase means the part of your menstrual cycle that is marked by between ovulation and your next period. But we know that everyone's an individual, and this could really range from 11 days to up to 17 days, right? And there are sometimes underlying medical issues that, for a variety of reasons, will lead you to have a really short luteal phase, right? And that is a real phenomenon. It could be problems with your thyroid, high prolactin levels, even things like anorexia or other reasons for your pituitary gland not being able to send those signals out are real organic causes of having a short luteal phase. And we don't really know enough about it and how or whether it directly impacts fertility, but it is theorized to play a role. And if you correct the underlying medical problem, it's going to help normalize the menstrual cycle and correct this issue altogether. So that's one thing. We're not saying that that doesn't exist, but the answer isn't to just throw progesterone, it's to actually correct the underlying problem of why the cycle's irregular. And then there's this other entity known as, you know, idiopathic, meaning it's not stemming from any known underlying hormonal imbalance or medical problem, but just this idea that inherently some people are just born with ovaries that don't know what to do and don't produce enough progesterone. And we don't really know how to diagnose that to confirm whether or not it exists. There's been a lot of different proposed mechanisms, like you mentioned, like measuring progesterone level 7 days after ovulation. This is problematic, and it drives me crazy, and it drives a lot of patients crazy, and they feel anxious about it, because measuring one level is not always going to tell you about the whole picture, because what a lot of people don't realize is these are pulsatile hormones, right? So your pituitary isn't just sending out a steady stream of luteinizing hormone to tell your body to ovulate, it's sending pulses. And there's actual data that shows there can be 8-fold times variability in your progesterone level during your luteal phase. Like sometimes you're going to catch it in a trough when it's on the lower end, and sometimes you're going to catch it when it's high. So you can't really just choose one static time point and measure a progesterone level and get the full picture. People have said, well, maybe you measure them daily over the entire luteal phase, that 2 weeks, or if it's a week or a week and a half, and add it up. And if it's less than 80 nanograms per milliliter, then that's a diagnosis. But that's really cumbersome. Who's going to do blood draws every single day? And that's still not really proven. And studies have looked at individuals who are known to be fertile versus infertile and having issues with conceiving, and the results are mixed. A lot of them have found no difference with any of these types of measures, whether it's blood work or looking even at the lining of the uterus. That's another way to look at this, right? Sometimes patients would get biopsies of the lining of their uterus, and your uterine lining transforms post-ovulation, post-exposure to progesterone. So you could say, okay, well, the lining should look this way when you take a biopsy of it and look at those cells under the microscope. And so they used to date the lining of the uterus and say, oh, you have a luteal phase defect because your lining is behind, right? It's not, or it's too advanced. And we know that that doesn't work. It's not reproducible. Even within the same patient, your cycle can vary, you know, and the results of those tests can vary from cycle to cycle. And B, studies have not shown that it's reliably been able to predict who gets pregnant and who doesn't. And it's really hard to study this, whether you're talking in the same person or between different patients, because if you're trying to understand the difference in a luteal phase between those that don't get pregnant in a certain cycle versus those that do, how do you measure a luteal phase in the pregnant cycle? You
Right.
never get your period, so you can't calculate that, if that makes sense.
Mm-hmm.
So it's difficult because there are no real ways to test for this. There's no standard definition of what a luteal phase defect is. And I suspect for those patients, we're not saying we don't believe you. If you have like only 9 days between your LH surge on an ovulation predictor kit and a period, we're not saying that that problem doesn't exist and that isn't a problem.
Mm-hmm.
But you need to have a full investigation. Are there other issues that could be causing that? And I would suspect that there are, because this as an entity in and of itself has not been proven to actually exist.
So I read, and you can correct me if I'm wrong, that the ASRM has defined a luteal phase less than 10 days as being not the standard, right? Or typical, right?
Correct.
That's still correct. Yeah.
Yes.
But I'm so glad you mentioned what you just said, because I remember when I was training, luteal phase defect was a thing, and people were getting diagnosed with it left and right. And what I'm hearing you say is that yes, people can have a shorter luteal phase, but we got to figure out why.
Yes.
It's not, if it's less than 10 days, there might be another underlying reason, and we can't just go say, here's a script for progesterone to correct that. We got to correct why it's happening to begin with, correct?
Right, exactly.
Yeah.
And also sending a script for progesterone, just to touch on what you said earlier about, patients who are prescribed it in early pregnancy, it's almost like a Band-Aid. Like sometimes it actually continues your abnormal pregnancy for longer, right?
Yeah.
It's not going to correct if your embryo has the wrong amount of DNA or wrong number of chromosomes. So, I think it's used too often, but I also understand wanting to control the situation.
Mm-hmm.
I also understand patients wanting things to be simple. Unfortunately, our biology is so complicated, and they want to understand. The number one question that I got DMs about in the lead up to our discussion today was, well, what level do I need? Like, we all just want to know what level is normal so we can
what's
breathe
the magic number? What's the magic number?
Yeah. Right. And the answer is there obviously is no magic number, but over 3 nanograms Ng per milliliter tells you a week out from your LH surge, or when you think you're mid-cycle, that you ovulated. But how much progesterone is enough? We don't really have a good answer. The way the lining of the uterus looks, if you look at those cells under the microscope, could look normal and appropriate with levels as low as 2.5, right? And we know that there's certain genes that get turned on and certain proteins that end up being produced. There's all these complex things that are happening in the lining of your uterus to prepare for an implanting embryo. And that pattern of gene expression appears to be normal with a range of 8 to 18 nanograms per milliliter. So if your progesterone level is 9, don't freak out because you read a blog that said it should be 15. It's pulsatile, remember that.
Right.
And if it's within that general range, I think that that's a good indicator that it could be a normal, healthy pregnancy. You just have to kind of see how things play out.
Right. That's such a great explanation. I want to make sure people understand what luteal phase defect means and what the evidence is now. According to, we've had a lot more data since I was training in residency 2004. And, we need to make sure we get to the bottom of it and find out what's really causing it and not just treat it with a Band-Aid, because even then the progesterone still may not work if we're not fixing the underlying cause. So that's a great explanation, Dr. Sekhon. I appreciate you explaining it that way. I understand it, but actually I understand it better now, the way you talked about it. And I might just go on and do RAI, since I think I could just learn from you.
I would love to work with you.
Okay.